You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 6, 2024. Our topic today is race-based spirometry, presented by Dr. Bridgette Jones. She is a professor of pediatrics and an allergist immunologist at University of Missouri, Kansas City and Children's Mercy Hospital.
Objectives today are to understand the history of race-based medicine and race-based spirometry measurement, understand the impacts of race-based medicine and race-based spirometry on patients and communities, understand what the current recommendations are to abolish race-based medicine and race-based spirometry, and particularly relating to pulmonary function testing, and then some of the implications that we need to think about going forward for the new modifications to move to non-race correction in spirometry. So first, I'll start just with a case to kind of center us to think about the patients that we see and why this is important and how this may apply. So AH is a 35-year-old Black female patient who presents to you with a 10-year history of intermittent shortness of breath, wheezing, and cough. She's a non-smoker. Her symptoms are triggered by upper respiratory tract infections, exposures to dogs, pollen, and cold air. Her symptoms have become worse over the past year. She was prescribed albuterol after having multiple visits to urgent care, and she uses her albuterol about 1 to 2 times weekly and denies nocturnal symptoms. So she was referred for these symptoms, and she had PFTs obtained using the Global Lung Initiative spirometry calculations, and so these are her results below. So FEV1 of 84%, FVC of 105% predicted, and her ratio is about 80% predicted. So what are your thoughts about this case? What would you do? What do you think's the best next step for her assessment or treatment?
Sounds like she hold on, I'm gonna make sure I didn't miss any details.
And it's meant to just be discussion. There's really not a right or wrong answer.
Yeah. I wanted to see that her FEV1 over FVC was a little lower, but it shows that she's not obstructed, but she is having symptoms, and she might be somebody that could benefit from like a glucocorticoid type inhaler.
Okay. So here's some more information for you. So her initial spirometry was done with race-corrected equations. So if you applied the GLI non-corrected or the white spirometry calculations, these would be her values.
FEV1 decreased, FVC 90 decreased, and then ratio is the same.
Yeah. So in this case, I think your recommendation is correct that, she's still someone that should be considered for inhaled corticosteroids, but there are some instances where I think clinicians might look at these values and say that they're normal, and especially when looking at the race-adjusted values, and make a different decision on her care. And so this is really kind of what comes into play with the current recommendations to utilize non-race corrected values and the potential differences in disparity of care due to race being incorporated. And so with that, I think it's important to talk about what race is and what race isn't, and how we use it in medicine and use it in science. And so does anyone know what the definition of race is, or a definition? There's probably more than one definition, but what is race? And there's some clues down below, but again, this is not a quiz. It's just a discussion. But what do you think race is, or race means?
feel like it's more like a social construct based on like someone's like physical characteristics.
Yeah, so perfect. So race is a social construct that is made up. It has been used to group people and develop this hierarchy of systems within our society. Generating racial classifications have been used to identify and distinguish often marginalized groups. It divides human populations into groups based on their physical appearance, social factors, cultural background, and it's been used primarily in the United States, is where kind of race was first defined, and then it's spread all across the world as a way to classify people, but a way to establish this hierarchy of different classes of citizens, and really is the tool that is used to implement racism. And so in 2000, the Human Genome Project was completed. And so these are two really important quotes that came out of that I don't think really got any attention, but one was from President Bill Clinton, who stated that, "I believe one of the greatest truths to emerge from this triumphant expedition inside the human genome is that in genetic terms, human beings, regardless of race, are more than 99.9% the same." So that's what we found, that genetically across all of these racial classifications that we had made up, we were all pretty much the same from a genetic basis. And then Francis Collins, who was director of the NIH, echoed kind of the same thing. "I'm happy that today the only race we're talking about is the human race. Thus, race is not a biologically reality, but a myth. Specifically, race as biology is fiction. Racism is a social problem, is real. For humankind, there's no such thing as a biological race because most human genetic variation is found within populations and not between them. And individuals are frequently more similar to members of other populations than to members of their own population." So this was in 2000, but just today, I think we're starting to recognize that race, we can't use race as a biological marker. And so that's what's led to some of the changes with spirometry. And so, as I mentioned, race has mainly been used as a tool for racism. So racism is defined as a system of power and oppression that structures opportunities and assigns value based on race. So these classifications that have been made up have been used to assign value to different people, and has been used to justify disadvantage and oppression of specific groups of people. And this has also been included in Spirometry. So this is one of the books that we'll talk about as we go through. And the author, Lundy Braun, who has been talking about this for a long time, of how racism has been embedded within medicine, and particularly within pulmonary function testing, as a way to dehumanize and to justify harm and oppression of specific groups of people, particularly enslaved African people and Black people within the United States. And so in American history, one of the first people to talk about race in regards to lung function is Thomas Jefferson. So he talks about in his speech on Notes on the State of Virginia in 1783, he states that black and white differences he describes a difference of structure in the pulmonary apparatus. He talks about this pulmonary apparatus being the regulator of heat in the body, and that a way to make this apparatus work better is to vitalize the blood. And to do that, you needed to, oh, is my camera off? I'm sorry. She turned.
I think they just turned off.
Yeah,
it was on before.
It keeps turning off and on. I don't know what's going on with it. But he talked about a way to vitalize the blood is by forced labor, basically. So in a way, justifying enslavement and justifying forced labor due to this defective pulmonary apparatus that required this vitalization of blood. So that's one of the first documented places where it's talked about. Now it's not letting me forward. Okay. And what a lot of his thinking, where it came from, was Samuel Cartwright, who was a pro-slavery plantation physician. So he was basically a physician that whose job was to make sure that enslaved people were able to work. And so he did a lot of studies where he was looking at oxygen metabolism, and he coined various diseases that he talked about were unique to enslaved Black people. And so he actually built the first spirometer. So he built this spirometer to be able to measure lung function in enslaved Black people. So it was really the first one, they think, who introduced race as a variable in lung function. So he helped substantiate what Jefferson had kind of postulated about this pulmonary apparatus. And at that time, it was really cutting edge because he was able to measure something and get these quantitative findings. So before it was kind of more postulation and kind of qualitative type thinking, but he was able to actually measure something and get something objective. So it was considered at that time, real science. So he measured this pulmonary function or lung function on enslaved Black people and determined that there was a difference where there was a deficiency in enslaved Black people of 20% in their lung function. So again, used this as a way to argue that this red vital blood was a way to correct this deficiency in lung function, and to do that was a way to do that was by forced labor. Even argued that enslaved Black people wanted to be enslaved because without being enslaved and forced to work really hard, they would die. He also coined terms like drapetomania, if you've heard of that before. So basically, he said, talked about that it was a mental illness if enslaved Black people wanted to run away and no longer wanted to be enslaved, and coined that as an actual mental illness that was unique to enslaved Black people. And then in 1869, Gould was another researcher who did this big study where, again, there was a lot of excitement around it because he was measuring lung function and had this quantitative assessment. And then he had this big cohort where he did all these anthropometric measures of Union soldiers. So it was one of like the first big cohort type of studies. So it was really viewed as like cutting edge, validated, true science. And so he rank ordered the sample of the soldiers by these different categories of white soldiers, sailors, students, full Blacks, mulattoes, and Indians, and reported decreased lung capacity measurements in all of the non-white subjects. Did this, without, of course, adjusting for height, age, occupation, and especially the socioeconomic and environmental living conditions, which were much different across these different groups. But again, concluded that the smaller lung capacity of the colored race is in itself a proof of inferior physical organism. So again, use this to kind of other a certain group and to determine another group inferior. And then the chief statistician of Prudential Insurance, Frederick Hoffman, wrote a piece called Race, Traits, and Tendencies of the American Negro that further enforced the racist ideas of inherent human qualities. He talks about that we are compelled then to believe that independent of external causes, so the conditions of life, that the Negro is far more susceptible to pulmonary disease than the white. The physiologic cause of this cannot perhaps be demonstrated, but great weight is due to hypothesis that he has a tropical or a smaller lung. So again, kind of postulating that there's something different about the inherent body of Black individuals, and that this is proof of an inferior physical organism. And this assertion is proved by the greater mortality of the race compared to white. Again, not taking into account the differences in conditions that Black people lived in at that time. But this was used as an argument against emancipation. So it was used as an argument that without being enslaved, that Black people would not be able to survive on their own due to this inherent deficiency in their bodies. And then it makes its way into medical literature. In JAMA in 1922, there was a study that was actually done in children, and at this time led to the establishment of these norms that we now use to determine what's a normal value or what indicates disease. And so again, they did pulmonary function testing and concluded that the Black children's values were outside of the norm values, but this wasn't due to social conditions. So again, this kind of set the stage for having these race-corrected values in spirometry. There were those who pushed back against this. So James McCune Smith was the first African-American physician in the United States and was an abolitionist. So, you know, he used narrative. He didn't have like statistical comparisons or objective data, but logically, he's like, this doesn't make sense. He thought that, okay, this is probably due to environment. And he talked about tropical, I think he named it tropical lung, or he talked more about the climate and the conditions that that Black people often lived in. And then Kelly Miller was another abolitionist and scholar who wrote the Review of Hoffman's Race, Traits, and Tendencies of the American Negro, and emphasized even more the social conditions that affected the lungs of Black people in the United States. And W.E.B. Du Bois also wrote about some of the same things. So they tried to push back on some of this, but it really didn't take hold, and it just became embedded in how we do things today. And so it really wasn't until the last couple of decades that you've started to see a few people talk a little bit about the deficiencies and the flaws in using these race corrections in spirometry. So Lundy Braun is a PhD researcher who has probably written the most and talked the most about this, especially in the first early decades of the 2000s. So she published a paper in 2013 looking at the American Thoracic Society guidelines on race and spirometry. And so she did a review of the literature that goes into those guidelines to determine whether spirometry researchers had defined race or ethnicity in their studies and how they explain the differences that were observed. So of the 226 articles that were published between 1922 and 2008, race and ethnicity were only defined in about 17% of the articles. The vast majority of them reported that other racial and ethnic groups have lower lung capacity compared to white groups, and the vast majority failed to recognize or examine the socioeconomic conditions and status that we now know more so influence spirometry measurements. Of the 189 studies that reported lower lung function in other racial and ethnic groups, most of them cited inherent factors or anthropometric differences. So the inherent factors of the individuals as the cause of differences in lung function between racial and ethnic groups. And so, despite, this knowledge, of incorrect race correction, and even like I mentioned in 1999 with the Human Genome Project, recognized that we're all much more genetically same than difference, is persisted. And so Lundy Braun wrote a book in 2014. In 2015, in one of her papers, she says it's time to rethink the problematic practice of race correction in light of the history. But it's been embedded within medicine in general, but particularly in lung function equations. So for the NHANES data and the GLI data that it's been used for reference equations historically, they estimate that there's a difference for Black patients of 12 to 15% lower than those of white patients for the NHANES, and for the GLI equations, 13 to 14% lower parameters. And so that's been embedded in how we practice just until the last couple of years. In 2015, there was a TED Talk that went viral, and it was actually, this was how I learned that race correction was incorrect. This was not taught, to me when I was in fellowship. No, it was just accepted that this was the right way to interpret spirometry. And so the way that I learned about this history and first started to question how we utilize race corrections was a TED Talk that went viral from Dorothy Roberts. I think it's a PhD researcher. I don't know exactly what her background is, but my camera keeps going off. This is how I learned about it, and pretty recently. And so I mentioned the NHANES and the GLI data that has been used historically for reference values. So in 1999, NHANES collected standardized data from non-tobacco smoking individuals without known pulmonary disease. And so these are the data that was used for the initial, for some of the initial reference equations. So when they looked at this data after correction for age, sex, height adjustment, they looked at these different racial categories that they came up with: white, African American, Mexican American, and observed that there were differences in the values across these different racial groups, and so decided that adjustments needed to be made to correct for these, what was thought at the time, inherent differences in biology. And then in 2012, the Global Lung Function Initiative Network was developed, and this was supposed to be a more comprehensive reference population. So it was supposed to include populations across the world and be a more representative reference population. So included ages 3 to 95 years, but again, use kind of these racial categories to look at potential differences in the values. And use reference values for white, which was labeled as Caucasian. We don't even use that terminology anymore of Caucasian, as we know that Caucasian is a specific ethnic group that lives in the Caucasia Mountains, but they use that labeling. African American, Northeast Asian, and Southeast Asian, and so decided that there should be these reference equations for these specific groups. And then they had another group that was an average of the coefficients across the 4 groups. So if you didn't fit into any of these, then you were in the other group, which is an average across the 4. And then in 2023, the GLI Global were developed by weighting the observations to reflect different proportions of the 4 racial and ethnic groups. So this method does away with having separate race corrected equations, and just has one reference equation for all of the groups, but the data is weighted based on the proportion of the racial makeup in the group. So it does still somewhat incorporates race, but you don't have a separate equation. So this you'll similar mean predicted values, but you just have wider limits of normal. So recognizing that within spirometry, spirometry, there's lots of variability that doesn't have to do with race itself. It likely has more to do with the differences in exposures and social environments throughout life of a person. And so having a wider limit of normal is probably much more accurate than limiting it to certain groups and trying to use that as a marker for their environment. So here's another case to think about. So MH is a 77-year-old Black male who is now retired, but previously worked at ABC Manufacturing Company as a forklift operator in the 1970s and 90s. During his employment, it was revealed that asbestos was used throughout the company buildings. The employees received compensation for asbestos exposure based on duration of exposure and documented lung function impairment determined by spirometry. And spirometry was performed using the National Institute of Occupational Safety and Health Spirometry training guide. And so the box below are instructions that I copied from their website. It's probably been about 6 or 7 months when I copied this, so I haven't gone back to see if it's still there, but this is how they suggested to utilize race. So they said to evaluate the pulmonary function testing, the operator must enter the subject's race. Attempts should be made to determine and record the employee's race or ethnicity. Often this can be done with adequate accuracy merely by observation. So we know that there's flaws in that, of course, right? So if in doubt, ask the employee examining that race, explaining that race affects the reference values used for the test. If the employee considers the equation objectionable, or if their race or ethnicity does not clearly fit the limited categories available, just record unknown and use the Caucasian reference equation. So, I think we can all recognize that there's a lot of flaws with this approach, but this is one of the ways that the occupational health impacts is one of the ways that it first became evident to Dr. Lundy Braun, and she talked about learning about the application of race correction when reading about the big asbestos lawsuits back in the late 80s, early 90s. So I don't know if you all recall or not, but in the late 80s, early 90s, there were lawsuits against asbestos manufacturers because there was a direct link between asbestos exposure and mesothelioma. And so there were a lot of lawsuits, class action lawsuits for people that had been exposed to asbestos. And so the company was arguing that there is an inherent deficiency in lung function in Black people. So they wanted the Black people in the lawsuits to be less compensated because they felt like their low lung values was due to inherent deficiency. And we also now know that even having a diagnosis of mesothelioma, there's a delay in diagnosis of mesothelioma and poor outcomes among Black individuals, and this is likely somewhat due to the way that race corrections have been used in spirometry and lung function measurements, where disease may not be picked up as early in those patients. So it has implications, far beyond even just outside of the clinical space that we're now going to have to deal with. And so, like I mentioned, Dr. Braun has been writing papers and talking about this topic, since the early 2000s at least, but it really wasn't until 2020. We had, the collision of the racial reckoning, what was described as a racial reckoning within the United States, along with the stark disparities, the COVID-19 pandemic, particularly showing severe racial disparities in who was dying from COVID, and recognizing all of the underlying chronic conditions and disparities across racial populations, and how institutional instructional racism have led to those disparities. And so One of the first things topics that started to be talked about was creatinine function in GFR, or glomerular filtration rate, kidney function, and how race-corrected values were leading to disparities in chronic kidney disease management, particularly for Black patients. And so that was removed from the GFR calculations. And then the American Academy of Pediatrics has a great policy statement on eliminating race-based medicine that highlights several areas where there's race-based medicine that's incorporated into medical practice, and discussing the reasons for removing these areas. So this really didn't get traction until 2020. And so these are examples, some of the examples of where race-based medicine has been incorporated, and the X's indicate the areas where it's now either being removed or has been removed. So I mentioned the GFR, but also things like BMI and risk for diabetes, probability of fractures, pulmonary function testing, of course, hypertension guidelines, UTI diagnosis in children. That's another area where recently there was a race correction factor, cardiovascular disease, as well as dosing for medications, believing that race equates to pharmacogenetic difference, leading to differences in dosing. So there's still many areas where it's still present, but I think now there's much more scrutiny and recognition of re-examining some of these areas. So to get to pulmonary function testing and spirometry assessment. So just in 2023, the American Thoracic Society put together a work group and had a big work group meeting to review the data and the history and come up with recommendations for moving forward. And this was after the GLI Global paper was published that talked about using these broader reference values without race correction. And so the key conclusions from this workshop were that the PFT laboratories should adopt a race-neutral approach to PFT interpretation by reporting and interpreting results using the average reference equation. So the GLI global equation is the one that is currently being used. And so they talk about other considerations in that, we can't, I think we're used to using like these strict cutoffs and using this one or two numbers to really kind of direct our care, and overall we need to have probably a more holistic approach in thinking about our patients. So how does the PFT measurement match up with the symptoms that they're describing and the impairment in how it's affecting their daily life. And there may be other additional tests that we may need to get or consider in the overall evaluation. So they recommend improving your PFT interpretation by taking the patient's medical context and social history into consideration in the clinic, emphasizing the value of longitudinal data, so not just taking that one snapshot in time. And I think this will be extremely valuable moving forward in tracking the patients against themselves and how their symptoms are doing with the values that you have in front of you, but looking at changes over time, as trending pulmonary functions over time provides potentially better clinical insight. They recommend that using the ratio might be a better and less biased approach. Has been shown to vary minimally across race and ethnicity. So especially relying on the FEV1 to FVC ratio for obstructive disease, and aiming to move beyond this simple statistical description of normal pulmonary function. I think for me in reading the ATS statement and reading some of the literature, what I now understand is that we really can't define what normal is, because there's so many different exposures throughout a person's lifetime that may or may not impact pulmonary function. And so I don't think we can necessarily say what is a normal pulmonary function value. So we need to move beyond that thinking. And, these are some of the limitations if you think about spirometry and pulmonary function testing. So what we're really using is a biomarker of lung function. We're not able to go into the lungs and see obstruction or measure. We're not measuring it directly. We're using a biomarker that's trying to give us an idea of how much air a person can blow out over a given time. And we're trying to use that data and compare that to other people that we think are normal and say, how we need to diagnose this patient or manage this patient. So I think we need to recognize it's just a limitation of biomarkers in general, because we're not doing a direct measurement. So we use that for diagnosis, and also as try to use it as a predictor of treatment response, prognosis, and risk. So, if you look at this curve here, and, if you have the obstructive disease down here and normal is up here on this curve, normal and above, there's a lot of people that are probably in this in-between area. So that's the area I think that we're going to have to start paying more attention to, of those people that fall, especially in the margins here, that fall here, and use that more holistic approach of their clinical history and maybe some other testing to help guide us in our decision making. And then the reference populations, as you saw, with the NHANES data, they included people that were non-smokers, and those that didn't have documented pulmonary disease, but it doesn't account for other exposures that may impact lung function. So defining what's healthy is really hard, and defining what's normal is even harder, like I mentioned before. And so currently we define normal for PFTs as lower limit of normal is defined as the 5th percentile of a given reference population. But again, I think having a reference population that is as representative as possible is key, in recognizing that there's wide variability that can occur throughout age. There's different exposures that can occur that impact your lung function. So there's a lot to consider here. So this is a paper that was recently published in New England Journal that talks about that kind of goes through some of the day-to-day or the implications of this. So could this impact patients? How could this impact society and public in general? So they calculated what the values would be they pulled data, publicly available data from NHANES and other databases, and calculated what the GLI global correction values would be. So moving away from the non-race corrected values. And so they looked at, what would happen when looking at diagnoses of obstructive impairment, so asthma or other obstructive diseases. So they found that with using the new GLI global corrections, there would be an increase in diagnosis of obstructive disease for Black, white, Hispanic populations, and decrease for Asian and other populations. For restrictive disease, there would be an increased diagnosis in Black populations and a decreased diagnosis in other racial groups. Same thing for COP severity grading. So they use kind of the current guidelines of how COPD severity is graded. So saw increases in severity grading for Black patients and decrease for other racial groups. For occupational eligibility, so this is one where, they talk about how this could potentially harm some racial groups by decreasing eligibility for Black people and for Asian people based on kind of the current occupational cutoffs to be a firefighter. So you'd have less people that are Black and Asian being eligible for to be a firefighter. But then if you look at VA disability compensation, which is often based on spirometry measurement, if your disability is for a lung condition, you would have increased VA disability compensation for Black and Asian populations and decreased compensation for white patients. And then this is just kind of putting it into some additional numbers here. So for obstructive disease, they estimated there would be 2.6 million more people, new people classified with obstructive disease, and about 500,000 that would move out of the obstructive classification, so no longer classified with an obstructive disease. About 428,000 more Black patients and 1 million fewer white patients would have a diagnosis of moderate to severe COPD diagnosis. There will be approximately 754,000 less Black adults qualify for firefighter jobs, and about 1 million more white adults qualify for firefighter jobs. And then you would also have increased compensation to Black veterans by 17% or $1.1 billion. And they even went to kind of estimate individually what that could mean. So an annual compensation increase of about $2,000 for 37% of Black veterans who are currently receiving compensation for lung disease. So again, these have real world impacts, and I think there's some complexities there that we'll have to deal with moving forward. So in the ATS workshop, they discussed these potential implications and talked about ways moving forward. If you have policies that have these race correction cutoffs, you can always change policies, and some of these policies probably need to be examined. You can change the threshold cutoffs for normal. So during the workshop, it seemed like there was some argument against the race correction, using race corrected values, because there was concern that it could actually harm some people by not using these corrected values with things like being eligible for a certain job. So these are some of the arguments or ways that we need to address this. So changing policy, changing thresholds, moving towards more holistic approaches, using additional testing to inform diagnosis and treatment. And I think the major benefit is, being able to correct misdiagnosis of patients, but also overdiagnosis of some patients. So, because that probably has been happening in some cases. So I think this not only impacts the groups that the race corrected values were developed for, but really impacts the patients overall, where maybe values have not been interpreted appropriately for the larger population overall. I think there does need to be a recognizing the harms and trying to move forward to correct those harms, and recognize that there's patient level harms, like I mentioned, of undiagnosed and mischaracterized disease. There's inequities in occupational hazard and compensation, but also how this has likely affected the larger communities and larger populations as a whole. So if you think about just the financial compensation differences for hazardous exposures like asbestos, et cetera, how this has likely impacted those communities as a whole. So these are some of the things that I think need to be done moving forward. So I think one of it are the device manufacturers, the pulmonary function device manufacturers moving towards the race neutral equations for pulmonary function testing. So I know that we've done that in our hospital, but there's still lots of devices and lots of equipment out there that people use where race correction is required for the device to even function. So, for example, I have a portable spirometer that we use for our research studies, and we want to look into utilizing the non-race corrected values, and that's not an option in the current device that we have. So I think the device manufacturers have a big role in this. As I mentioned before, just in the way that we practice, making sure that we're considering holistic approaches. I think professional organizations and medical societies have a big role in disseminating this type of information, getting the information out there of the history of race correction, and starting to remove that from any guidelines, policies, and examining overall how we've been incorporating race in medicine, not just for pulmonary function testing, but if there are other ways that we have been utilizing race in an inappropriate way. And so all professional organizations and medical societies advocating for this elimination of race-based medicine, like the AAP policy. Workers' compensation claims probably need to be re-examined, policy and procedures of insurance companies may need to be re-examined as well. And then, of course, education of clinicians, students, trainees, everyone just needs to be educated, I think, about this. And I think the history is really important to also know of how this happened. So that we can think about moving forward as we continue to have innovation and science, to recognize some of those flaws that happen with people just being excited about, I think, somewhat the innovation that some of the people were able to do with these objective measures. So I think there's a lot of lessons in the history. And then educating the patients and the public as well. I'm not sure that currently we're doing a whole lot to tell the public about these move away from these race corrected values and how this may have impacted them as patients or as public citizens, and what they need to do to be able to take care of their own health. And so in the ATS report, there is a supplement that has some language there that they recommend be included in spirometry or PFT results given to patients, explaining to patients about the race corrections that have been used and how their spirometry is going to be interpreted differently going forward. It's a little wordy. I'm not sure it's very patient friendly, but I do think having some wording to inform our patients is important. So next steps, other approaches that they also talked about is standardizing the FEV1 to powers of standing height. So different ways to interpret the PFT results, looking at things like chest size and chest dimension in the calculation as well, to maybe get a more accurate result. But certainly considering the socio-environmental exposures that lead to differences impacting pulmonary function and spirometry, I think that's going to be really important from a research perspective of thinking about the reference populations that we use and the different socio-environmental exposures that probably need to be considered in those reference populations. And then, as I mentioned, work is needed outside the initial healthcare setting, so places like Veterans Administration and occupational health. There needs to be a recognition of these changes and work to implement these changes in a way that doesn't harm patients. And then I think overall increasing diversity of populations included in research. Again, the initial reference populations may not have been, as representative of the general population as it should be. And so going forward, I think this is another lesson of having diversity of your populations, not just across race and ethnicity groups, but different environments and different exposures. In research helps to yield a much more generalized population to guide research and be able to have valid results. So with that, we'll have a little quiz, a little friendly quiz. Just have about 5 questions we can kind of just go through. So question 1, the early idea of decreased lung function was inherent to the Black race was introduced by which former president? You guys remember?
Thomas Jefferson.
Thomas Jefferson.
Yeah, perfect. I was supposed to have some animation there, but it didn't work. Okay, question 2. Which statement below is the correct definition of race? So race is a social construct used to group people. It was constructed as a hierarchical human grouping system. Race is the color of someone's skin. Race is defined by their genetic makeup, or race is defined by where your ancestors are from.
A, the first one.
Yeah, so it's a social construct that's made up. Previous NHANES and GLI lung function parameters estimated that Black patient lung function parameters were how much lower than white patient values? I think I mentioned this or it was on the slide. I want to take a guess.
Is B?
Yeah, so the NHANES and the GLI, both of them had estimates of 12 to 15 and then 13 to 14% lower for Black patients. There's a true and false. Genetic variation between race or ethnic category exceeds that within a given race or ethnic category. So is that true or false? So if you look at the genetic makeup between different racial groups, there's more genetic variation between different racial groups, or there's more genetic variation within race and given race and ethnic population.
I would say between the different groups.
So actually, it's
true or false.
Yeah, so yeah, my animation isn't working. So it's actually, that's actually false. So there's actually more genetic variation within racial and ethnic populations than between. So we're all much more alike than we are different.
Got it.
A pulmonary function with an FEV1% of 80% of predicted normal values indicates A, a normal lung function, B, an abnormal lung function, in the case the patient was premature, in the case the patient lived next to a highway, or all of the above.
This is a tough one.
Yeah, it's kind of tricky. Kind of tricky.
I guess, would it be all of the above? Because
yeah, it could be any. So I think, again, the take-home point is, we have to get away of these like defined, like cut off values, especially, 80% is kind of right on that line of what we think of as normal. So it could be normal, it could be abnormal, it could be any of these factors could be true. So again, kind of interpreting the whole patient, even though I only gave you a little bit of information, but that's the take-home point is, we need to think of all of these potential options. I think that's it. So these are